This is Nursing Uncensored. I'm your host, Adrianne Benning, and I invite you to listen in on conversations I've had with real nurses about the crazy and wonderful lives we lead. This podcast is meant to create laughter in addition to serious discussion, and nothing is off limits. We're always honest, but we're not always safe for work. Please listen responsibly. Welcome to Nursing Uncensored. I am here today with a special guest. We are talking to Chelsea. Hi, Chelsea.
Hi.
How are you?
I'm good, thank you. How are you?
I'm good. You're in California, right?
Yes.
Is it beautiful there? I need to know. It's like freezing here.
Oh, now I feel bad, but yes, it's 70 degrees.
Don't feel bad. I love it. One of my friends is in Florida right now, and he keeps texting me and being like, you should be here. It's gorgeous. But you know what? I live in Iowa by choice. It's okay. Welcome to the show, though. I'm excited to talk to you today. We're actually going to talk about a topic that I know other people are interested in because you are not alone. What are we talking about today? We are talking about specifically bipolar disorder and also what it's like to be a nurse with bipolar disorder. Is that right?
Yes.
Yeah. Okay. So if you would first, I would love for you to take a minute or two to just tell us about yourself, what kind of nursing you do, and how bipolar has touched your life, basically.
Okay, sure. So I've been a nurse since I was 21, so about 7 years now. Wow, just realized that.
Congrats.
Thank you. And I work in a pretty small county hospital, like a community hospital. So I think you mentioned you worked in a teaching hospital, like academic
it's pretty big.
medical center.
Yeah.
That's so cool. Yeah. We are not an academic or large hospital, but we do have a really good residency program. So that's pretty cool because our residents are so good to work with. Yeah, that makes a big difference because they're so respectful and receptive to our nursing feedback and so smart. So it's really cool.
Good.
And I also work in ICU step down. I think you said that's where you work too.
Yeah. Mm-hmm. Yep.
Yeah, and it's pretty cool. We don't have specialty floors, so ours is sort of a general floor that we see so many different things. But if someone does need a more intense specialty care, we have different hospitals that we can quickly stabilize them and transfer them to.
Cool.
And then we see a lot of respiratory and CHF, and then a lot of alcohol and drug withdrawal, sepsis. And we're not an end-of-life unit like you mentioned that you do, but we actually pretty often end up taking care of end-of-life patients if they don't have the insurance to go home with hospice or to a hospice center. So that's something I'm just learning about. It's really difficult. So yeah, I admire you for doing that so frequently.
We all have these different things that we do, and to other people it seems really hard and difficult. And I don't know, I feel like once you find your spot, you've got to nestle in. I think it would be really hard to work in a county hospital, like a smaller hospital, but that's just because it's so different than what I'm used to, you know? But I think that's cool. And you probably do see a lot of interesting stuff because with progressive care, I mean, even though we are also primarily respiratory, we can pretty much take anything. I've had patients with everything from finger abscesses to brain tumors. So,
whoa, I've never seen a finger abscess.
It was weird. It was we take a lot of general medicine patients. And so we can take a lot of different things. I'm sure you probably see maybe not the same things, but it sounds like you probably see a lot of different things since you're kind of general progressive care. That's pretty cool.
I enjoy it. And we recently started taking the more unstable postpartum patients, which I know nothing about, but just hemorrhage and high blood pressure, seizures, HELLP syndrome, all those things. So at first it's so scary. I Googled what is a fundus and how do you
Oh my gosh, yes.
It's so different in the deep tendon reflex. But
cool.
I'm
not at all good at that stuff.
Yeah, it's so different. And then you do get to see babies, so that's happy.
Yeah, that's pretty cool. We don't do any we have a whole separate department for mother baby care. Once I took care of a pregnant patient, but she was nowhere near delivery and she was having respiratory issues. But just the fact that she was pregnant was so scary to me because I'm like, we only had half a semester of maternal care.
Exactly.
So yeah, I feel like grown-up nurses and baby nurses are they like to stay in their comfort zones. So
yeah, definitely.
So, what was your education before going to nursing school? Did you have difficulty in high school or had you figured out by then how to talk a little bit about that? Because I know that bipolar disorder can have some effects on your mood and ability to concentrate and stuff like that. So also at what point in your life were you diagnosed? Sorry, I just threw 5 questions at you.
Oh no, that's okay. That's multitasking is something that nurses are good at.
Yep.
I would say. So high school, I was fine, just quiet, really into school and try to get a 5.0 and all that crazy stuff. But after that, I guess the best way to describe how it sort of emerges, I guess, is that some people have a genetic disposition to bipolar disorder, and I do have a family history of that. But just because it's in your genetics doesn't always mean that you'll get the disorder. So the way that my psychiatrist described it is that you have to have the genetic disposition, but something usually kind of turns on the genes. Not very scientific, but that's
but that makes sense. It triggers it. Yeah, something triggers that gene, turns it on. Yeah.
Yeah. So he said it could be anyone that had sort of a traumatic childhood, which is definitely not me, which I'm grateful for, but could be just one event that can cause it. So in my case, it was after college. I was actually already in the 3rd year of nursing school, so good thing I didn't have to deal with it for the first 2 years. And it was after sexual assault, and that, I'm not saying that to get sympathy or anything, just the facts. But after that is when I started to notice a big shift in my mood, getting depressed to the point that I couldn't go to school and clinical, which before I was super on top of it, and then getting sort of too much energy and then making up for all the work that I missed when I was depressed, and even to the point that I couldn't sleep at night. I would just lie in bed and feel I have so much energy. I need to do something and go running around San Francisco in the middle of the night, 10 miles up and down hills, and just felt like this is a great idea, not thinking about safety risks or why am I not sleeping? So while it's happening, it feels really fun. But after it's happening, you kind of look back what was I doing and why?
It's just the way you feel. It just kind of comes on. What prompted you to think oh, maybe it shouldn't be like this?
Well, at first, right after that happened, I thought I'm just depressed because of what happened, which would make sense. But then when I started feeling better, I said, oh, that's good. I guess I got over it quickly. But then I started feeling super better. And I'm like, wow, this is even better than before. Yeah. But it's just after a while of feeling when you're in the kind of the manic part, you just, at first, you don't know what it is, so feel this is great, maybe it'll last forever. But after you notice that the higher it goes and you kind of have the crashing down, you start to get more nervous when you are in the manic phase. So then it took me a long time, maybe 7 years to go to the doctor, which I think is pretty common because people enjoy that. Yeah, so that was not good. But after a while, it just became apparent this is not normal.
I was doing some research because so when we first started talking, one of the things that you clued me in on, which I didn't know, is that there are different types of bipolar disorder. And this, even though I have family members who are bipolar, this wasn't something that I ever knew. I feel like this wasn't really, maybe they did talk about it in school and maybe I was so overwhelmed I missed it. But I would love for you to talk a little bit about what you know about the different types of bipolar disorder.
Oh, sure. Yeah, I don't remember learning it in school, but like you said, you're trying to learn
Yeah. I've been like reading some things, and I watched some YouTube videos. There's actually, I can't remember her name, but I think she's a clinical psychologist on YouTube, and she makes a lot of videos. And she did one that I actually watched today. I'm actually looking in my history to see if I can find it. Katie Morton. I don't know if you've ever heard of her, but she's a really great clinician that does like informational videos. So anyway, please, I didn't mean to interrupt you.
Oh no, that's okay. I'm writing it down so I can.
I'll put the link in the description, because it really is a great summary of the different types of bipolar disorder. So it was great information for me. It's like a 10-minute video. So I'll put that in the notes, and I'll send that to you as well. But yeah, I'm sorry. Please continue.
Oh no, I'm sure that she can describe it better than I can. But from what I learned after the diagnosis and everything is that the main two types would be the bipolar 1 and bipolar 2. And they're pretty similar in that it's kind of swinging from mania to depression, and sometimes like normal in between. Mm-hmm. So the mania is basically the same, that you would have a lot of energy, confidence, maybe not need to sleep, or if it gets really severe in the type 1 bipolar is when you could experience like psychosis or what they call that delusions of grandeur stuff, mm-hmm. and maybe some really reckless behavior, as in like spending a lot of money or making friends with people that you don't really know, or like high risk sexual behavior, something like that. And then the bipolar 2, they also experience depression the same way as in bipolar 1, but their high part is called hypomania. So it's the same symptoms, but it's not so severe that it would impair their functioning, and you wouldn't be hospitalized for hypomania or experience psychosis.
Yeah. And actually, that's the perfect description. That's exactly how it was explained in this video. And that, you do have like the highs and the lows, but you don't hit those high points of mania with type 2. So that I imagine that it's probably harder to diagnose type 2 because you don't have these like very clear periods of this like intense mania where you're not sleeping. You think your self-confidence is awesome. You don't really feel the need to interact with others because you're like riding high on your own thing. You don't have to talk about anything you don't want to talk about, but may I ask which type, do you have type 1 because of this mania that you were describing of like not sleeping and like being kind of reckless and like wanting to go out in the middle of the night?
Mm-hmm. Yeah, mine is a type 1, and I'm happy to answer any questions.
I appreciate that. This transparency is great because you're not the only one who has probably experienced this. And like you said, it took you so many years to seek treatment. Did you think like, this is probably, who knows what this is, but maybe not? I don't know. Like a lot of people don't think they're like, whatever, this probably isn't the best, but it's fine. I'm functioning. Like it's okay.
Yeah. For some people, it takes like being hospitalized to get the diagnosis, which fortunately was not the case for me. But a lot of people either never get diagnosed or they resist the diagnosis because a lot of celebrities and creative people are actually diagnosed with that. And some people say, if I take the medication, I won't have the manic episodes that help me be so creative, whether it's acting or art or singing or anything like that. So I understand why people don't want to take the treatment, but I thought that was interesting, the long list of famous people. But unfortunately, many of them died pretty young due to substance abuse or suicide. So that's encouraging that you should get the treatment.
Yes, for sure. The family members that I have that have bipolar, I feel like based on what I'm learning, they might have been more of a type 2 where they have the kind of the roller coaster ride between that hypomania and then depression. But yeah, those episodes of psychosis can be really scary and can be really dangerous too, especially if you're someone that doesn't have like a family member that lives with you or someone that's close enough to you that would like notice. So Yeah, that can be really scary to experience this and not really know what's happening. But it sounds like you didn't have like a traumatic like hospitalization or anything that got you your diagnosis.
Oh, yeah, but I think what you just touched on, having social support, is so important because where I work at the county hospital, our patients tend to be lower income and lack of resources or access to resources, and maybe not the social support that I'm really lucky to have, and the education that I was able to get. And a lot of them do have bipolar disorder, depression, schizophrenia, but because they don't really get to know what it is and get formal treatment, they'll kind of use substances to combat the symptoms, and then end up with some pretty severe physical health problems. So it's very sad to see that a lot.
So it's basically easy to develop bad coping mechanisms if you don't have, if you're not seeking treatment, if you don't have someone supportive in your life. I'm glad that you do have that support. I know that there are some people that struggle not having that support. So how, you said you were already like in your third semester of nursing school. How did that, or your third year of nursing school, right?
Mm-hmm.
How did that all play out? Like, how did that go with like finally saying to yourself, like, I think something's up here. I need to see a doctor. I need to be treated, whatever it is. Like, how did that progress and how did that affect school?
Oh, well, I didn't say that anytime during school, but for a little while I was just very depressed and I didn't show up at the clinicals or the classes, and it was very out of character. So the teachers kind of reached out and said, well, what's going on? If you don't come back to school, you're going to fail. So luckily I was still, alert and oriented, as we say at work. And I just said, well, I need to go back to school. I don't want to make it this far and then fail. So just kind of like pretty much forced myself to get out of bed and go back to clinical and finish everything. And after it kind of swung back up, I was able to catch up on everything and read all the things that I missed and do extra hours in my preceptorship, since my preceptor was nice enough to let me do that and work with some other preceptors. And it was easy to work like 6 12-hour shifts in a row when you have that kind of energy. So I guess because it was so low and then so high, and I never experienced psychosis, the overall outcome was somewhere in the middle, and I was able to finish. Yeah.
Okay, well, good. So now, you've graduated, you passed NCLEX. What does that look like now that you're a nurse, or in your early days of nurse? Let's start there. In your early days of nursing, what did this look like for you? Like, how did this shape up in your life?
Well, after I graduated, I took the test right away, and luckily I passed, and I think went into like the high of passing the test, or I don't know why, but went back into a kind of manic swing, and I decided like I need to get a job right away or I'm going to forget everything that I learned in school. And where I live, because it's the San Francisco Bay Area, it's really hard to get a hospital job as a new grad, and even just anywhere in the state, because the pay is high, even though it doesn't make up for the super high cost of living. But a lot of hospitals have the option to only hire nurses with a lot of experience because they're willing to move here for the high pay. So they don't really need new grads.
Sure.
Yeah. So I applied so many places and then, just never heard back, not even a rejection, just nothing.
That's
and that
so
was
frustrating.
Yeah. And all my friends were having the same experience, unless maybe they knew someone there, or they just gave up and went to nursing home or clinic or hospice, which is not, those are all really important jobs. But I just got obsessed with acute care. Like, I need to do it or I'll never do it. And then I just said, I'll take the first job that they offer me, no matter where it is. And I've never lived anywhere besides the Bay Area, which I later found out is like its own little country, little bubble thing. So it was a kind of really bad idea. But a lot of my classmates did go to Texas, and they said, you should come with us. It'll be like the California Coalition. But I don't want to wait for that. And I ended up taking a job in Little Rock, Arkansas. So I thought, like, this is a great idea. I'll just move to Arkansas. Everything will be fine. And I'll work in a hospital and maybe I'll come back in 2 years and I'll get a job in California. So that's what I did.
Wow. So you did. You spent time in Little Rock.
Yes, I spent 7 months there. It was supposed to be 18 months, but just being away from home and the no support because I didn't know anyone. Although I did make friends at work, I just was getting so depressed that I wouldn't even like accept their invitations to hang out. And it was really different, like the food and the culture, and there's still pretty segregated, I would say. And here, a lot of my friends and my partner are African American, and there it was just not really acceptable that you would hang out with like Black people if you're white outside of work. At work, everyone interacted and seemed like it was fine. But if I would ask like a Black coworker that I felt we were becoming good friends at work to maybe go out after the shift, everyone would just look like, no, you don't do that. So it was really hard for me to learn like the social norms.
Yeah, that's very different. I mean, I grew up in Chicago, so it's like I was a minority in a lot of rooms that I was in. So that would be huge culture shock for me too, to like go somewhere where suddenly there are these like really kind of not good, like racial tensions and norms. Like that's hard. That's hard to navigate, especially when you're coming from a place where you're like, we all just kind of hang out. Like it's cool. It's not that big a deal. Yeah, that would be hard for me to get used to.
Yeah, it was so uncomfortable. But here, there's racism everywhere. But I really like,
of course, yeah.
Yeah, here it's a little different. I love having diverse coworkers and patient population, and there it was pretty much like 50% white, 50% Black, and don't really interact. And there would still be like older white patients that would refuse to have a Black nurse, and we'd have to change the assignment. And I was just like, wow, I know the history there is quite different, but
yes,
it was a culture shock for sure.
I bet. And then on top of it, to then be there without really, a group of people that you can like, feel comfortable with. Because then when you've got all these new people that are like, come out with us, and you're like, thanks, no thanks.
Yeah, I should have said yes. There were so many friendly people there and some great things about
it's so
Arkansas.
easy to say that, though. It's so easy to say that as someone who has had some pretty paralyzing social anxiety at points in my life. Sometimes it's not that easy. Like I've had all of these memories of like these grand intentions. I had to do things, but then when it comes right down to it and your brain or your emotions are like, nope, not going to do it. I don't care how much you want to, not going to let you do it.
Oh, I would never guess that about you, to have social anxiety.
I mean, honestly, everybody thinks I'm really outgoing, and I can be, but I kind of learned that at my job. As a kid, I was really shy. If you had told me at the age of 12 that I would grow up and have like a podcast that people listen to all over the country, I would have been like, bullshit. Never. I would never do that.
Wow.
And even now when I get like negative comments or whatever, it's really hard for me not to take it incredibly personally. So that's like, yeah. And, I can be really outgoing, but then when I come home, I'm like, I can't talk to another person for at least 15 hours. Like if I go out to a show or a party or something, I'm like ready for the door after like a couple hours. Even if they're people I really like, I'm like, okay, guys, my social meter is maxed out. So yeah, very true about me. But I can turn it on. I'm like a cheetah. I can sprint for very short amounts of time, and then I have to go sleep for a while.
Oh, that makes sense. But as long as you can put it on for your patients, then that's perfect.
Oh yeah. I step out of the patient room, and I'm like, I hate this. And then I go,
oh, no.
What can I do for you? I would love to tuck your pillow in. And it's not phony. I can channel it when I need to.
Oh yeah, definitely.
So you spent 7 months there, and then were you just to the point where you're like, I need to be back around my people, like I need to have my support system and my friends and my family, and so back to the West Coast after that?
Yeah, I just want to clarify, I'm not trying to hate on Arkansas at all.
No, 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 no.
It is, yeah.
Nope, not at all. But very different places. We love our nursing brothers and sisters in Arkansas, but very, very different. So
Yeah, it's a beautiful place though. The natural beauty is so amazing, and it's the only state where they have diamonds naturally in the ground, which I learned. Pretty
nice.
cool. Yeah, and you can
I
do
think
hiking.
I can't remember if this is true or not, but I think Arkansas also has like really pure quartz mines. I think maybe
Yeah, that I think that's true.
yeah.
And there's no traffic, which is so much better than
That's
the
great.
Bay Area.
It is in the South, so you've got the benefit of like Southern weather. Like,
Yes,
yeah, no, we're not hating
good.
on them.
Food is good. People are friendly. Nobody is like here in Silicon Valley just looking at their phone and ignoring you. They all would
Yeah.
wave to me.
Mm-hmm.
It's so different. Like random people in their car. You're passing them in your car and they wave to you.
That's how it is in some places in Iowa too. Yeah, you're like people give you like the hat tilt, and you're like, oh,
yeah.
nice. I grew up in Chicago, so like you don't smile at people you come across. You'd be smiling you walk by. Here in Iowa, I like see somebody and I like smile at them and they smile back. So
yes, I really like that. And like people, if you go for a walk and they're sitting on their porch and you look, maybe you're tired or sweaty, they're like, hey, do you want some lemonade? And then you can just sit on their porch and drink lemonade.
That's the South. It's not like that in Chicago, but that's awesome.
No.
So,
it was great.
But yeah, so no shame. But yeah, and then you went back to California, and there you've been since, yeah.
Yes.
So you got you did some exploration. That's more than a lot of us do. So
yes, and also the ratios there were pretty. At least in that hospital, here we have legal mandated nurse to patient ratios, and those nurses worked so hard on day shift. We were on a medical unit, but equivalent to what we call step down at my hospital, and they can have up to 7 patients on days and up to 9 on nights.
Whoa. That's unreal for me. Like on progressive care, we do 3.
Yes,
3 to 4 is a lot, but we'll do 3 to 4. But we've also got patients that are on like ventilators and like it can be intense. So you can have a chill group, or you can have a group that is like fixing to go back to the ICU because they're, you never know. So
you guys do ventilators on step down?
Well, we only do ventilators to trachs. So we're not doing ET tubes, but we have a lot of patients that are trach to vent, whether it be chronically or just like acutely while they're in, we take like post lung transplant patients. And
wow.
So yeah, even though we're step down, we do a lot of crazy, scary stuff. But then at the same time, we also get patients that come in because like, they have like CF, cystic fibrosis exacerbations or like congestive heart failure, and they need to be like diuresed and like stuff like that. So it can range between people that are just like here for IV antibiotics and people that are like, they have the vent and a trach and a chest tube and a feeding tube. And like, yeah, it can get pretty intense.
Post lung transplant sounds really high acuity.
Yeah. We actually take transplant patients after they've been in ICU anywhere from 2 to 5 days. The fastest we've seen somebody come out of ICU is like 2 days after lung transplant, and they're up and walking. Mm-hmm. It's intense.
Isn't that a painful surgery too?
It is. And that's why for the first few days after they come out of surgery, they usually have an epidural, and then we bridge them over to either IV or oral pain medications.
Wow, that is so interesting.
Yeah, someday I should do an episode about that.
Yeah, I want to know more about it.
Yeah, that's really cool. And, once in a while, we also take care of patients that are like old liver transplant or kidney transplant. So there are special considerations for them. But yeah, but progressive care can look different depending on where you are, because like it's true in some smaller hospitals, their ICU is more like progressive care at bigger hospitals. But all of the hospitals play an important role because we need that elevated care everywhere, even if it's a matter of like stabilizing someone and getting them to a bigger facility. You're still doing a really critical component by getting them stabilized and getting the right care.
Oh yeah, definitely. Well, thank you for saying that.
Yeah. Every piece is important. I can't do my job unless you guys are doing your job, and vice versa, you know?
hmm
So let's talk a little bit about how you, like in your kind of present day life, ways that you help control your symptoms and make sure that you're kind of staying away from these like extremes of mania and extremes of depression.
Yeah, I do take medication, and luckily I found one that works and doesn't have a lot of terrible side effects that a lot of typical antipsychotics do, like weight gain, diabetes, drowsiness, tremors, all things that you wouldn't want while you're working as a nurse. So mine is it's a medication that's primarily for seizures, but it's also an atypical antipsychotic that is studied and proven to be effective for bipolar disorder. So I only take the one medication. It just took some time to get it to the right dose and make sure that the side effects were tolerable, but it's working really well. And so I'm grateful for that, because a lot of people have to go through so many different medications, and then
Right,
they
to
might stop
find.
working, the side effects are too much, that type of thing.
Sure. So, is this something that you've like talked to your employer about, or have you? How does that work? I mean, obviously, it's none of your employer's business if you don't want it to be. However, are there things that you have told them so that maybe, I don't know, are there special considerations that your employers had to make, or have you just found ways to deal with it pretty well so that you don't need to involve them? Like, how does that fall?
Well, I was hired on to day shift, originally 40 hours, but I was able to cut it back to 32, not because of the bipolar disorder, just that a position came available.
Sure. Yeah.
But yeah, and I used to pick up like extra stay over for PM, do night shift and day shift, all those kind of rotating shifts to try to help out when we're short staffed. But the doctor recommended probably day shift is the best because it goes with your natural circadian rhythms, and I'm more of a day person anyway. But if you do pick another shift, then stick with it. Only work that shift and keep your sleep schedule, get enough sleep, and try to like sleep at the same time and wake up at the same time. So I just stopped picking up the evening and night. And at first I didn't tell them why, and they kind of had gotten used to me filling in the holes. So they're like, "Hey, what the heck? Aren't you
Where'd you
going to work
go?
whenever? Yeah, where'd you go? Work whenever we need you." But um, I just said I couldn't do it anymore. And then later on, when I was increasing the medication for the first few days that you increase it, it will kind of make you kind of sick and dizzy and stuff like that, and have a really bad headache and throwing up. So I couldn't really go to work. And I just got the FMLA temporary for just those few days from the
Sure.
psychiatrist. Yeah. So I
So
did
that,
show it to my boss, and she didn't really care. She's like the most strict manager in the hospital. So I think she only cares about whether you're doing a good job and that you're not texting or drinking coffee at the nurse station.
as long as you're doing your job, we'll keep the peace. We'll make it work. So it sounds like keeping a consistent sleep schedule is like really important for like maintaining kind of that even keel. So do you find that if you, when you were kind of switching back and forth, was it like increasing your symptoms or like making it harder for you to like do the things you need to do in the way you want to do them? I mean,
Oh yeah, definitely. I really liked picking up night shifts because some of my good friends work nights, and then it's just kind of a fun environment. Like our boss doesn't, not that I do love my boss, but she doesn't walk around and throw away your coffee and confiscate your phone and look at your room and find every little thing that was wrong and that your tubing expired 1 minute ago and something like that. So it's a little, not that it's easier or relaxing, but it's just a different environment.
different
But
vibe.
yeah, different vibe. But when I would pick up night shifts, I would just get like more manic energy, I think, because I pushed myself past the point that I should have been sleeping. And then it kind of went too far. And while most people took like their 1 hour nap break, I would just go outside and go for a run for an hour and
Oh
come
my
back.
gosh.
Yeah, another night, the night runs began again. And the coworker's just like, what is wrong with you, girl? But it was kind of crazy. And then I'd have trouble sleeping the next day. So just eventually said, I can't work nights anymore, but they still invite me to the breakfast. So it's good.
Nice. Okay, good. You still get breakfast, but you also get to sleep and like manage your symptoms a little better. So that's really good advice for like students or other nurses that maybe are dealing with similar symptoms, is like make sure you're, because even when you don't have something like this to deal with, it's still really hard to switch back and forth. So I know that I've had those periods more so when I was younger. Now, oh my God, I sleep all the time. But when I was younger, I could do that. I could stay awake for 2 days, no problem. And then and then sleep for the next 2 days. So it was, it's never good on your body to treat it like that. So do you have advice for like students or nurses that maybe are listening to this and going, oh my gosh, this describes me? Like, what would you suggest they do if they think that maybe this is something that they are experiencing?
I would say get the treatment as soon as you think there might be something wrong. Just go ahead and get the evaluation. Even though it's scary, it's better to know and prevent something really bad from happening. And other than that, if you do get the positive diagnosis, don't be afraid of medication, but you can, if you have a good doctor, like I discussed with him what side effects I can't tolerate and probably would be non-compliant, as we say about our patients. And then he was really nice and let me kind of not pick from the menu, but he went through all the different types and how they work, how effective they would be, and then said it's different for every person and side effect profile and all that. So if you have a good doctor, which it could be hard to find, especially in some areas where there's so lack of access, but there are some new apps and stuff that connect people in more rural areas. So
yeah.
Yeah.
I've seen, no, but it's true. Like a big part of it is like maybe people are having these symptoms, but they're like, well, my doctor doesn't really listen to me, or I don't have a doctor, or whatever. So it can also be scary. There's a lot of stigma that comes along with this, with any mental illness or any kind of psychiatric disorder. A lot of people have a lot of opinions that maybe aren't quite so nice or quite so correct. Have you had any experiences with people? I mean, it sounds like you've got a really supportive community and a great like support group just among your personal friends, but have you come across anybody that's been like ignorant or non-supportive, or I don't know, has anybody given you any crap about it?
Not to me personally. The only people that I had to tell at work is my boss, and her response was pretty interesting. I would say positive, because she just didn't really react at all. She just said, well, your work performance is good. If it's not good, I'll let you know. And
okay, so she wasn't like, oh my God, this is so horrible. Yeah, it's like, okay, well, you're managing it. You're doing a good job. So keep doing what you're doing to manage it, right? How do your friends and family play into that support? Like, well, what do you need from them that helps make this better?
All my friends and my family and my partner, they're all really supportive. And I've only told one coworker about it, and she really helps me if I'm having a bad day. Like, oh, you can go outside for a minute, and she's usually the charge nurse, so I'll keep an eye on your patients, whatever you need. So that's great. And then the only thing I think I've experienced negative is like in the media, or if you hear people who don't really understand that it's the manic depression rather than just someone who's like really nice and then really mean all of a sudden. And they'll say like, oh, he's so bipolar, and it's just not
You're like,
accurate.
well, no, thank you for making light of something that's not quite correct. But yeah, I've heard people say stuff like that. It's not helpful. Like when people say like, oh my God, I am so OCD. Well,
yeah.
But you're not. And people that actually have OCD probably don't find it amusing that you're like, I'm so, well, this is a real problem for people. So maybe don't say that.
Yeah.
You can be like a little bit, retentive or detail oriented, but that doesn't mean, So people say stuff like that just because they're not thinking. I think that it's nice to just, gently remind them that maybe that's not the way to talk about things. For those listening, we want to really drive home that like, you can be a nurse. You can give good care to other people and still have your own medical conditions that you need to take care of. Some nurses have diabetes. Some nurses have arthritis. Some nurses are bipolar. And it doesn't mean that now, of course, if you ignore your symptoms and you don't do things that you know are good for yourself and you refuse treatment, those can be problems down the road. But,
yeah, definitely.
But I would rather have a nurse taking care of me that has dealt with mental health issues and has successfully taken care of them than someone who like has no experience, because I want to know that someone understands me. And
definitely.
And it's much easier to talk to people when they know what you're going through. So I think that as nurses, it's important that we, of course, I'm not saying you need to tell your patients your personal business, but sometimes it can be really healthy or helpful and therapeutic to say to people, I get it because I've dealt with it, Have you ever had an instance where like you've come across someone that you've met them or you've known them for a while and you're like, you might be bipolar too?
Well, not in my personal life, but at work. With our patient population, definitely a lot. We see almost every day alcohol withdrawal and CHF related to maybe meth use is really common, or cocaine, heroin use, sepsis from injection drug use, and like endocarditis from sepsis from injection drug use. Yeah, and then sometimes when the alcohol withdrawal people come in, they're just very altered that you couldn't have a conversation with them, and just getting like 200 milligrams of Ativan, but somehow still jumping over the side rail. So that is pretty crazy. And you go home hearing that bed alarm in your head and IV pump beeping and monitor going off and stuff. I'm sure
I think all nurses can relate to that. Just the stimulus that you're like, oh my God, if I have to hear that alarm one more time, I'm going to lose my mind. We all know how that feels.
And the call lights and just people screaming.
Oh yeah. When you hear
it, my God.
It's been a long time, but I do have memories of times where I like sat straight up in bed because I thought I heard a bed alarm in my sleep.
Oh my gosh, really?
It's been a long time since that happened, but it has happened.
That's terrible.
I know. But then these things pass. You get used to things. Heart monitor alarms too. Like I really try to pay attention to the alarms because we have a lot of we have respiratory patients. So we have a lot of patients that like refuse to wear their BiPAPs, but then all night long they're dipping to like 88 and 89%. So you're like trying to convince them to wear their BiPAP. They won't do it. And you're like, but I can't turn your alarms off. And you're snoring. And every 5 seconds you're alarming and I'm going to lose my mind.
And they don't wake up. And then
they don't hear it. They're like in their bed. They have no idea. And you're like, oh my God, the alarms.
That used to scare me so bad when they had like really long periods of apnea. I'm like, get the crash cart. And then it happens like every other.
And you can't say this, but you want to be like, sir, I'm afraid you're going to die in your sleep. Can you put your damn mask on?
Please wear the BiPAP, or let me change the setting to 85 and below, but you can never do that.
Right.
Of course.
It's like, man, don't make me code you because you're like apneic for like a full minute. Come on.
Or keep going in there, slapping their chest. Hey, you're not breathing.
But it's true. It's so true. So I think that really it's important that we all as nurses support each other, but it's even more important to support each other when we all have shit that we deal with at different points in our lives. And we should never assume that someone can't be a nurse because of something like this. Clearly you've proven that your work is good. you're a fantastic nurse, I'm sure, just from talking to you, because it sounds like you really try hard from the moment you were in school. I mean, I'm really impressed with people who say that they're like, they're like aiming for these like 4.0, 5.0 statuses in nursing school, because nursing school is hard. Oh my gosh, it's so hard. So, I think it's really important that we like destigmatize this and like remind people that this is not something that keeps you from being a great nurse. In fact, this is actually something that can make you a better nurse, because you have understanding of something that maybe other people don't understand,
because a lot of the people that come in with those conditions, like I said before, it's from mental illness. So other nurses, they're all great people, but I have heard them say like, oh, these crazy people, why do we have to work with them? We're not a psych unit and stuff. Because we tend to see the people when they're at their psychiatric worst, or combined with the effects of substance intoxication. So we get a really bad perception of mental health, and that can be really hard to look at. Like, this is the worst outcome, or hopefully, like, sometimes I feel that's inevitable. That's how anyone with mental illness is going to end up. But like you said, if you have that empathy for them, even if your circumstance is different in terms of your socioeconomic privilege or something, you can at least relate to them on the basic level of knowing the symptoms that they go through, and kind of treat them with less judgment and hopefully more respect.
Respect and compassion, because I mean, none of us are immune to any kind of illness or disorder. So you need to be nice to people, because this could be any one of us. And I think that it's important that you are on the show today. I think anytime we're bringing light to something that maybe people don't understand, even healthcare providers, even those of us in the field maybe don't understand this sort of thing. Or we do say things that are insensitive, like, oh my God, that guy's so crazy. Well, be careful how you throw that around, because how would you feel if suddenly you started having weird symptoms that you couldn't explain and they came out of nowhere and you can't do anything about it? You don't want people talking shit about you. You want people to help you, support you. So this is a call to all of those listening. Try to remember that, like, you don't always know what's going on with someone. So be supportive, do your best. And if it's someone that you care about, I think that you need to be careful about how you approach it, but say like, hey, I've been noticing things are different with you. You want to talk? What's going on?
Oh yeah, definitely.
These conversations can be important, especially when they're non-judgmental. Somebody might be just waiting for the opportunity to say, I don't know what's going on, but I need a hand. So I think it's great, everything we've covered today. I think this is a lot of really great information for people. And I'm really glad we were able to talk today. This has been a long time in the making. Do you have any other messages or anything else you want to tell our audience about this? You've got the mic. You've got the floor here.
Oh gosh.
I know I'm putting you on the spot. I know. But I mean, really, with everything that we've talked about, I think that you're a good example, because I think that you're even talking about it openly and honestly is really important, because people can get really scared to talk about these things, especially when they're experiencing it and they don't quite know what's up. So yeah, I don't mean to put you on the spot. I think that you had a really great message and a lot of great info here today. So.
Oh no, that's okay. I was just going to say thank you so much for giving me the platform to talk about this issue, and just for your acceptance and positivity. And I think you don't have to have a mental illness to give empathy to patients that do, because to me it sounds like you definitely have that respect for that population, and as well as all of your patients. And you sound like an excellent nurse and an excellent podcaster.
Thank you so much. Yeah, really, I want everything that we talk about to be something that can help somebody. And your story is just really compelling, because you have great information. And I'm so happy that you've shared this all with us. There are a lot of people that might not be so eager to put themselves out there and talk about their experiences. So this has been awesome. Thank you so much. for those of you listening, you can, I don't have a resource on hand right now, but I'm going to look something up. Do you know of any organizations or resources that are helpful for people with bipolar disorder? I mean, I'm really putting you on the spot here.
Oh, no, that's okay. There's one that's called the DBSA, and I honestly forgot what it stands for. But that one is a good resource. And then, well, for me, in terms of nursing, listening to this show has helped me a lot, especially the one that you did about going to a patient's funeral, because I was put in that situation recently, and it was actually the patient had fetal demise, and it was the baby's funeral. So I felt, oh gosh, if she invited me, I better go, but is it appropriate? Just all these back and forth.
All the feelings.
Yeah, so that one really helped me.
Okay.
So this show is a great resource for any nurses, nursing students, or people curious about the life of nurses.
And I did Google DBSA. It is the Depression and Bipolar Support Alliance. So I typed in DBSA to Google, and it was the very first thing that came up. So I'll put the link for that in the show description so that people can link to it and check it out. That's actually a great resource. I was going to suggest like the National Alliance for Mental Health, but this one sounds like it's even more specific. Yeah. So I'll include both of those. But yeah, that's fantastic. That's a great resource. I want to encourage folks not only look this stuff up, but check out nursinguncensored.com. We have episodes, the blog, the vlog, all sorts of stuff on that website. It's kind of a catch-all. It's like the Nursing Uncensored universe all under one roof. So encourage people to check that out. And really, I guess that's all there is to say. I want to thank you again, Chelsea, for spending this hour with me. This has been really great. And I hope you really enjoy the temperate weather out there in California. I'll be here under my blanket and heating pad until at least April.
Oh man, well, enjoy the friendly people of Iowa.
Oh well, thanks. I'll wave to somebody for you today. Yeah. All right, awesome. All right, well, we'll catch you guys next time, and happy nursing, everybody. Here at Nursing Uncensored, we may be, well, uncensored, but we're not unfiltered. Protected health information has been changed and concealed to comply with HIPAA. The things we talk about are from years of experience with thousands of patients, things we've read, stories we've heard. If you think we're talking about you, we're not. Also, we're real nurses here to provide helpful and accurate information, but don't take anything we say as fact without doing your own research. Refer to your state's Board of Nursing, Practice Acts, and your institution's policies and procedures if you have questions about your practice. Lastly, our very strong opinions are ours alone and do not reflect those of our employers, educational, or professional institutions. Thanks for listening, and happy nursing, folks.